Hi, everyone. My name is Vincenzo Berghella. We're again at the new sessions at AJOG MFM Live. My pleasure again to be here with Dr. Mhatre. Mo, why don't you introduce today's session?
Sure. Everyone, nice to see you again. I'm Mo Mhatre. I'm one of the MFM attendings at Tufts, and I am the program director for the MFM Fellowship Program. Today we sifted through all of the fantastic articles that were published in the September issue at AJOG MFM. And here we have highlighted 4 articles that we thought would be really important for anyone practicing obstetrics and managing patients on the labor floor. And so we're just going to start off. All of the articles are available on AJOG MFM in their totality. Why don't you go ahead, Dr. Berghella?
Yeah, we picked data from randomized trials. They're the ones that often change practice. This first one is minimizing tearing during vaginal delivery with a perineal protection device. So somewhat of a new idea. Perineal tearing is a big issue. And the idea here was to see if either standard manual perineal support or this new protective device would be better. And here's the protective device. You can see on the right side, primiparous patients at term were randomized to either this device, using this device to, as you could tell, decrease tears, first, second, third, especially third and fourth tears. And that was the primary outcome. And then preventing maybe even other tears. Some, again, were randomized to the device, 43, 49 to routine care. And actually, the device decreased the risk of second degree or higher laceration by 60%. So that's a easy device to use, major prevention of the worst laceration. There was also less labor tearing with the device, and only 4 patients will need to get the device to prevent a second degree tear or higher. So this kind of shows that using this device, again, small trial, but randomized, it's something that we should study some more and see if it helps. Again, third and fourth degree tears in particular can cause years of angst, future surgeries, sexual, pelvic floor, all kinds of problems. So excellent trial.
Yep.
Why don't you take the next one?
Absolutely. So here we have from Dr. Maki et al. Looking at a randomized controlled trial evaluating barbed versus conventional suture for cesarean uterine scar defects. And what this group was trying to evaluate was at a primary section, which type of suture would be best for decreasing the rate of cesarean scar defects, which obviously impact future pregnancies. This is a multi-center RCT performed in Japan, where they randomized patients who underwent primary cesarean to having a 2-layer hysterotomy closure with either barbed or conventional suture. And then at about 6 to 7 months post-op, they did a transvaginal ultrasound, and they evaluated not only the rate of the scar defects, but also how big they were. And so they randomized about 110 patients to both the barbed as well as the conventional suture group. And what they found was with the barbed suture, those patients had a significantly lower rate of actually having the defects, and then niches were smaller in size. And using this suture did not impact operating time, blood loss, or other surgical post-op complications. So this study found that having barbed suture may actually decrease the rates of myomutual defects after primary cesarean, and should be something that we continue to look at and investigate at a larger scale.
Yeah, and there's some data also that barbed sutures are easy to use. You can actually do the C-section a little bit quicker. So I think that this is something that it's also beginning to change care. So very interesting data, Mo. The next one I'll take on, it's a study actually from India. So we're going all over the place, Japan, India, and it's something very hot, tranexamic acid in preventing postpartum blood loss. This is vaginal delivery. I'm actually a believer that a C-section, tranexamic acid can really help in preventing postpartum blood loss, or this is prevention trial. So I was interested in reading this, and we worked a lot on this paper and eventually got published. And the idea is this tranexamic acid prophylactically decrease the incidence of postpartum hemorrhage and blood loss. Single center RCT in India, basically, late preterm or term, undergoing vaginal delivery. They got 1 gram of TXA or placebo within 2 minutes of delivery, which is most of the trials for vaginal delivery. That's when you give it as soon as the baby basically comes out. And then they looked at postpartum hemorrhage as primary outcome. And this is actually a larger trial. It's, in India, they do 26 million births, so it's easier to do larger trials. Unfortunately, they didn't find any difference in the primary outcome, postpartum hemorrhage, or other, blood loss, intravenous transfusion, adverse events, and not embolic events. So it was safe, but really not that efficacious. So they say kind of, wait. Certainly, tranexamic acid seems to be very promising when given at C-section, if you give it before cord clamping prophylactically, but at vaginal delivery given right after the baby comes out doesn't seem for now to prevent. It's good for treatment of postpartum hemorrhage, and so I want to make sure we give the message, use tranexamic acid to treat postpartum hemorrhage, but at vaginal delivery, this trial was negative. Yeah. So,
All right, and to wrap up, so this study was in the United States. This is an adjunctive azithromycin used in scheduled cesarean sections in patients with obesity. This is a secondary analysis of a larger RCT. The question is what type of antibiotics are best in obese patients who are undergoing a scheduled cesarean to reduce the rates of surgical site infections? Do we need to just continue our current routine antibiotic regimen, or should we also add azithromycin on top of that? And so this was a secondary analysis. The RCT was a population of obese patients who were actually involved in a negative pressure wound dressing study. And when they looked at the exposure of patients who had adjunctive azithromycin, they had 291 patients. All of them happened to come from one study site. And those particular patients did not have any difference in having surgical site infection rates compared to the routine antibiotic regimen. And so what they concluded from this study is that adjunctive azithromycin does not appear to decrease the rates of surgical site infections for obese patients having a scheduled C-section. Interestingly, that study site had published their own study previously and found potentially some benefit. So we have 2 trials with conflicting information. And I think what this shows is really an RCT would be the best way to answer this question once and for all. So I look forward to anyone who wants to take on that challenge.
And if you go back one slide real quick, clearly there was a decrease, it's just...
Yeah, it's just like a board.
Yeah. So I think azithromycin has certainly, potential, like you say, more randomized studies in the future. Yeah, that's it. Thanks, everyone. Maybe you want to give the last word, Mo?
Yeah, thank you, everyone, for watching. We hope to continue this next month, and you can look forward to some highlights from our October issue coming up soon. Thanks so much, everyone. Have a great day.
See everyone soon. Thanks, Mo. Thanks a lot.